Thank you. Dear Chairman, dear colleagues, at first I'd like to thank the organizers for the opportunity to be involved in this wonderful session. My presentation is dedicated to the topic of cell therapy possibility for decompensated liver cirrhosis and to make an attempt to answer an important question, whether or not cell transplant, either primary cell or stem cell based, is a viable therapy to treat liver diseases. I have nothing to disclose. The need for cellular transplantation to become a viable therapy to treat liver disorders is obvious. In liver cell therapy, two main approaches and related cell sources have been attempted: replace function and modulate microenvironment. Since 1992, after the first clinical hepatocyte transplantation was performed in Japan, no more than 150 cases of successful clinical hepatocyte transplantation have been described. Hepatocyte transplantation is a highly promising approach for management of inherited liver metabolic diseases and acute liver failure, but has remained experimental due to the limited cell sources, cell engraftment, and liver repopulation issues. As an alternative, extra-embryonic mesenchymal stem cells possess multipotency and remarkable immunomodulatory features with robust and constitutive anti-inflammatory and antifibrotic properties, making them suitable for the treatment strategy for different acute and chronic liver disorders. In comparison with adipose tissue MSCs, extraembryonic ones may carry out more significant potential in liver failure treatment. MSCs ameliorate lipid storage, restore tissue homeostasis, and improve engraftment of human hepatocytes in animal model. The high rate of deceased donation with established allogenic tissue bank that included human hepatocytes, various types of mesenchymal stem cells, and others served as the background for the cell therapy for liver disorders in Belarus. We have previously shown that intraportal, local, and systemic infusion of allogenic adipose tissue MSCs during liver transplantation and liver resection is safe and feasible with promising immunomodulatory and pro-regenerative effects. In order to treat decompensated liver cirrhosis, the study aimed to evaluate the safety and potential therapeutic effects of intravenous placental MSC infusion as well as intraportal human hepatocyte transplantation in combination with placental MSC. Placental MSCs were isolated from the placentas of healthy women who underwent cesarean delivery with signed informed consent and ethical committee approval. The chorionic plate as a source of MSC was chosen based on the high differentiation potential and significantly higher secretion of hepatocyte growth factor in relation to MSCs from other tissues. Hepatocytes were obtained from discarded deceased liver grafts and from the parts of living grafts in case of LDLT needing graft reduction. High levels of proliferative activity and the capacity for osteogenic, adipogenic, and chondrogenic differentiation were seen in MSCs isolated from the placental complex. Immunophenotype matched the requirements set provided by the International Society for Stem Cell Research. An interventional prospective case control study was conducted. 46 patients were included, adult patients with decompensated liver cirrhosis demanding inpatient treatment with total bilirubin of more than 6 mg per deciliter and awaiting liver transplantation were included. Patients with portal vein thrombosis, sepsis, active bleeding, and cancer were excluded. The period of observation was from 6 to 22 months. There were two different therapeutic approaches. The first one, intravenous systemic placental MSCs infusion in a peripheral vein, 20 patients, and intraportal percutaneous transhugular human hepatocyte transplantation combined with placental MSCs, only 3 patients. It was sequential infusion, at first MSC for modulating microenvironment and next hepatocytes. There were 3 cases of hepatocyte transplantation. 2 patients had native liver cirrhosis and 1 had liver transplant cirrhosis. Their ages were 42, 33, and 46-year-old, with a median MELD score of 27. In one case, a combination with TIPS procedure was used. In another case, perioperative immunosuppression was prescribed due to persistent liver transplant. No surgical complications, no surgical site, no portal vein thrombosis were revealed. However, in one case, there was deterioration of portal hypertension leading to variceal bleeding and hepatic encephalopathy requiring urgent liver transplantation, which was subsequently performed. The 1-year survival rate was 33% in this group. Here is a clinical example. A patient, 42 years old, with acute and chronic liver failure and decompensated alcoholic liver cirrhosis. Hepatocyte transplantation combined with MSC was combined with TIPS procedure. Hemostasis stabilization and bilirubin improvement were achieved, as well as clinical condition. Unfortunately, the patient passed away 6 weeks later due to septic COVID complications. Another arm, 20 cases of systemic placental MSC infusion. No side effects or complications of administration were observed. There was a significant decrease in total bilirubin by 39% and an increase in total protein, as well as albumin and prealbumin. Also, stabilization of coagulopathy by 25% was achieved, resulting in significant decrease of MELD score. Out of 20 patients, 40% were successfully transplanted, while 10% of patients died, one on the 8th day due to profuse variceal bleeding, and one 8 months after due to severe pneumonia. The remaining 10 patients, 50% had stabilized clinical course, which possessed to observe them at the outpatient clinic. The 1-year survival rate was 85%, which is significantly higher than the control group's rate of 56%. We proposed clinical intraportal human hepatocyte co-transplantation with placental MSCs for better engraftment and enhancing functional activity. Percutaneous transjugular intraportal delivery of cells was a safe surgical procedure. However, in cases of severe portal hypertension, intraportal cell co-transplantation may lead to portal hypertension deterioration. To prevent this, it can be combined with the TIPS procedure. Systemic intravenous placental MSC infusion did not cause any negative effects. In patients with decompensated liver cirrhosis, this infusion stabilizes the clinical course, providing additional time while awaiting an urgent liver transplantation. Of course, further investigations are needed to overcome limitations and improve outcomes in hepatocyte transplantation and MSC therapy in liver disorders. In summary, and the presence of severe portal hypertension restricts the clinical use of intraportal hepatocyte transplantation. Systemic intravenous infusion of placental mesenchymal stem cells is a promising therapeutic option for patients with decompensated liver cirrhosis, which may serve as a bridge to liver transplantation, especially in urgent cases. Thank you for your attention.